All right, so let's talk about three factors that affect cardiac output that are not in the heart rate world, okay? So, first factor that affects cardiac output is called preload, okay? And also known as, it plays into so-called Frank-Starling law. So the feature of the cardiac muscle is that when it is more stretched, it produces more forceful contraction. Does that make sense? It's a unique feature of cardiac muscle. So basically what it means, imagine that this is the heart. My hands represent the heart, right? So if you load it with blood to that extent, it will contract with a certain force. If you load it with blood so it stretches like this, it will contract with a bigger force. Does that make sense? So at the end of the day, the larger volume will still be expelled, will still be ejected from the heart. Okay? So basically, the idea of preload plays into into the narrative of the more blood you have in the beginning of ventricular systole, the more blood you have before the actual ejection, the better. The higher, well, not the better, but the higher the cardiac output will be. Does that make sense? So basically, preload is can be transpired to higher end diastolic volume. Does that make sense? How much blood can be returned to the heart at the end of diastole? Are we clear? So what can lead to the increased preload? What can lead to higher end diastolic volume? Reduced heart rate. It kind of makes sense if you think about it. Think of it this way. When the interval between ventricular contractions is increased, so when an interval between the contractions is increased, it gives your heart more time to be filled up with the blood. Does that make sense? That makes sense. Good? Okay. And then you have muscular and respiratory pumps. So what are those? So if you think about it, blood is returned from systemic circuit into the heart through which blood vessels? I think we talked about it briefly. Okay, which blood vessels carry the blood to the heart? Category, in general. Veins, right? Veins. That's what I'm asking. I know that I couldn't ask it any better. So veins carry the blood to the heart. Does that make sense to you all? So veins are, the walls are pretty thin, and the way to propel blood through the veins is partially via muscular and respiratory pumps. Here's what happens. When your muscles contract, when you do exercise, when muscles contract, they bulge. And when they bulge, they squeeze veins that are between them. That makes sense? And it's like a toothpaste effect. So they like squeezing the blood through the veins. Clear? The higher the physical activity, the more muscles you are contracting at a given moment, the more blood will be returning into the heart through the veins. Does that make sense? Now, respiratory pump, like right now, our breathing rate is, mine is a little bit higher because I'm talking. but it's nowhere near our breathing rate when we exercise. Does that make sense? Now, here's what happens when you inhale really massively. Look. So your chest expands, your abdomen kind of pushes back, right? So that pushback squeezes the blood from the abdominal region of vena cava into thoracic region, and expanded chest creates lower pressure, which additionally propel blood towards the heart. Does that make sense? So that's a respiratory pump due to the breathing. And reduced heart rate, muscular and respiratory pumps, all of this results in increased end diastolic volume. Another term for this preload is venous return. Okay, does that make sense? So we can, in other words, we can say that increased venous return transpires into increased EDV, which then increases cardiac output. Does that make sense? Okay. Clear? Good? Now, second factor that affects cardiac output is so-called contractility. So contractility is the force of contraction at the given degree of stretch. Okay, does that make sense? So cardiac muscle, check this out. Your cardiac muscle, when your heart is at the end of diastole, when your heart is fully relaxed and is filled with blood, are you following me? Your heart is stretched out. Does that make sense? So at this particular degree of stretch, heart can contract with different force. It depends on certain factors. So that ability to contract with a certain force is the contractility. So far, does that make sense? Agents that alter contractility are called ionotropic agents. And basically, contractility depends first and foremost on the concentration of calcium. So agents that increase contractility are called positive ionotropic agents. And that would include, well, calcium ions. Okay? It will include thyroxine, thyroid hormone, epinephrine, norepinephrine. Okay, does that make sense? So far, we good? Now, let me ask you sort of a next question. Not too hard of a question, but interesting question. So, contractility is the ability of the heart to produce a powerful contraction. So let me ask you this. Which parameter will be affected by changes in contractility? End diastolic or end systolic volume? And systolic volume. You're absolutely right. Does that make sense? Because this is your heart, right? Like with the blood. If contractility is poor, look what happens. This. So you have that much left. Make sense, right? If contractility is good, this is what's going to happen, and you have that much left. Much less than that. So higher contractility results in the lower end systolic volume. And how does lower end systolic volume, and I probably should put the equation here. So cardiac output, remember, equals heart rate multiplied by EDV minus ESV. So if you, check this out, if you decrease end systolic volume, how will it affect cardiac output? Will it increase it or decrease it? Increase it, right? So that results in the increased cardiac output. And conversely, lower contractility is due to negative ionotropic agents. And there's a really strong temptation to immediately say that negative ionotropic agents would include acetylcholine, but they would not. Two that I want you to know are potassium and acid. Okay? In acidosis, the ability of the heart to contract is reduced, as well as in the presence of high concentrations of potassium. Does that make sense? Are we clear? Okay. Now, last little bit is after load. We're going to go back to contractility in a few minutes because I want to highlight something. So after load is basically, how much blood is left at the end of, kind of increased ESV, increased end systolic volume. Does that make sense? Now, after load or end systolic volume, what does it depend upon? So let me ask you this. Let me ask, kind of minor. Remember when we were talking about the heart anatomy, we mentioned that ventricles pump the blood out, right? Let's talk about left ventricle for a change. So left ventricle, does anyone remember into which great vessel the blood is being pumped? That's right. Left into aorta, right? Now, aorta leads to the systemic circuit, correct? And you can measure blood pressure in the systemic circuit. Make sense so far? Your left ventricle has essentially to work against some resistance, some pressure. Does that make sense? Now, I want you to think about what I'm going to say. The higher the blood pressure, the higher the afterload. Does that make sense? When your heart has to work against certain resistance, if that resistance, the systemic blood pressure is high, more blood will be left in the ventricle. Does that make sense? Are you following me on this one? So, the higher the resistance of the circuit, the higher the blood pressure in the circle, the more blood will be left in the ventricle after the ejection. Does that make sense? Because your heart pushes against higher resistance. Got it? It's bacterial. I know what it is. It's bacterial bronchitis. It's not COVID. Okay? I know. I have this a few times a year. So essentially, we can say this, that increased blood pressure will result in the increased end systolic volume, and that, if you look at the equation, will result in the lower cardiac output. Does that make sense? Questions so far? Now, before I'm going to say a few words about contractility versus heart rate, I want to highlight something. We, as always, we use what's called the reductionist approach. We deconstruct a really complex system into elementary building blocks, and then we consider each building block independently. Does that make sense? In reality, it doesn't happen like, oh, the only thing that increases is preload. No, it doesn't happen. when you think of it this way, when you are exercising, when you're working out, your heart rate goes up. Does that make sense? But at the same time, your muscular and respiratory pump do go up as well. So at least your EDV is the same, and your heart rate goes up, so cardiac output increases, right? And due to the sympathetic stimulation by epinephrine, norepinephrine, contractility of your heart increases, so that reduces ESV. Okay? But to some extent, your blood pressure goes up, so it may actually blunt a little bit that reduction of ESV. You see what I'm saying? So now, to make it easier, sort of when I'm going to be asking, like, let's say my question is, how does increased end diastolic volume affect cardiac output? When you answer this question, you have to consider this is the only thing that changes. Everything else stays the same. Am I clear? So like, if I ask, that's the only thing that changes. We good? Okay, now, few words about contractility versus heart rate that we discussed last time. So, if you look at two systems, sympathetic and parasympathetic, you will notice, and you know, the main neurotransmitters for sympathetic will be epinephrine and norepinephrine, and for parasympathetic it will be acetylcholine. So if you will compare how sympathetic and parasympathetic regulators affect contractility and the heart rate, you'll notice this. Look, sympathetic increases heart rate and increases contractility. So both. We're good? Parasympathetic, check this out, has no effect on contractility. It reduces heart rate and that's it. Does it make sense? It's important to remember. Questions? Good? It's important to remember. Parasympathetic system has no effect on cardiac contractility.
So is sympathetic fight or flight then?
Yes. Yes, that's fight or flight. Yes, exactly. This is fight or flight. This is rest and digest. Okay? We good? And that kind of feeds into a clinical sort of application here about cardiac output. First of all, let's say cardiac output at rest should be pretty much the same. Do you agree with me? So like, if you would take an average-sized person, like average-sized person like me, right? And you take like 3 people of the same size with the same blood volume. At the end of the day, we should have the same cardiac output. Does that make sense? We may achieve it by different routes, so to say. So let's say an example. Let's say I have hypertension. Does that make sense? Chronically high blood pressure. Chronically high blood pressure increases my afterload. Does that make sense? Which increases my end systolic volume. In the short term, like if it's the question on the exam, you should say, well, cardiac output will go down. Does that make sense? If I ask you how it changes cardiac output. In reality, I can't afford it. It can't happen. Does that make sense? So if my end systolic volume goes up, are you following me? And my stroke volume decreases, how will it be compensated? Through heart rate. You see what I'm saying? So an example of this, I can give you an example. My mom she has hypertension. Okay, it's managed hypertension, but she does have hypertension. And she's not young, so her heart is weaker. It doesn't contract as efficiently. Does that make sense? So both hypertension and lower contractility increases, I should put it here, increases end systolic volume. Is that clear? Her ejection, the stroke volume that my mom's heart can produce is smaller than my stroke volume. Does that make sense? So her heart rate will be and is higher than mine. My resting is about 55, 60. Hers is about 80. Does that make sense? So basically she compensates through heart rate, she compensates for reduced stroke volume. Does it make sense? We good?
That's long term.
That's like life-wise, so to say. Okay, does that make sense?
Is it a different effect short term?
What I'm saying is, imagine, well, again, we look at each individual factor, how it affects, but if your cardiac output decreases, you're going to die because your tissue perfusion is going to go down. So it will, the cardiac centers in the medulla oblongata will compensate for it. Does that make sense? I mean, I kind of put myself in a difficult position because I start with very straightforward, decreased contractility, higher ASV, lower cardiac output. But then I tell you, well, actually it's not going to be a lower cardiac output in the long term because it will be compensated. But yeah, in the short term, yeah, it's going to change. Does that make sense? But then it will be compensated. Okay? Now, it kind of feeds into a clinical presentation. You probably have heard about the condition known as congestive heart failure, CHF. So what is the mechanism of congestive heart failure? Well, think of it this way. Imagine that you have a patient with incredibly high blood pressure, right? That makes sense? So heart has to pump against much resistance. You with me so far? Now, heart is a muscle, basically, right? When your muscle works against a resistance, what happens to the muscle? It's hard, really doesn't.
Overwork.
Do you go to the gym?
Gets tired.
Well, it's not the ultimate goal why you go into the gym, right? There are two outcomes. When you work out, what happens to your muscles?
They get weak.
Huh?
They get weak.
You work out and they become weak, they become strong, and they also become big, right? Does that make sense? Your muscles hypertrophy. Does that make sense to you? When they become big like skeletal muscles, yeah, we all embrace that, so to say. What happens if your cardiac muscle starts to become bigger and bigger, because it needs those extra fibers to push the blood? Are you following me? It's going to increase in size at the expense of the ventricular volume. Are you following me? So your left ventricle pumps the blood into the aorta. When it has to pump against increasing resistance, the volume of the left ventricle will be lower and lower because the muscle will be thicker and thicker. Does that make sense?
So it's getting thicker on the inside.
It ends up being thicker on the inside. Ventricular, and only left ventricle in this case. So left ventricle becomes smaller and smaller, which automatically means your EDV inevitably will go down. And at some point, and when we say compensation can only go that far. Okay, this is called cardiac hypertrophy or hypertrophic myopathy, okay, when muscle becomes bigger. And in this case, cardiac output on the systemic side will decrease. Does that make sense? So this is the left side failure. Left side basically fails left side fails to comply with the proper cardiac output. Does that make sense? Alternative to this, by the way, another type of cardiomyopathy, and I'm not qualified to tell you what is the mechanism like for development each of those, but another option, so to say, is when ventricle, instead of becoming the one with the thicker walls but smaller volume, it's called dilated cardiomyopathy. When listen, when ventricle stretches out and remains stretched. Does that make sense? So the walls of the ventricle, I have illustrations in the notes. The walls of the ventricle are of a normal thickness, but the size of the ventricle is enormous. And this means that it's still, that big muscle, it can't effectively contract because it's too stretched out. Does that make sense? Like ballooning, okay? And this dilated cardiomyopathy will also lead to the decreased cardiac output. All of it, so if left side fails, this results in the congestion of the blood in the pulmonary circuit. Does that make sense? Now, which circuit, and I think we talked about it, pulmonary or systemic, is, tougher? You know what I'm trying to say? Like, mechanically more resilient. Which circuit is more tougher? Pulmonary or systemic? Okay, walls of which circuit are more fragile? Pulmonary, because the pressure in the pulmonary circuit is lower. It doesn't have to withstand 120 over 70, right? So, if you have pulmonary congestion that results in pulmonary hypertension and pulmonary edema. So basically your blood vessels in the pulmonary circuit become leaky and fluid starts to accumulate in the lungs. Does that make sense? Are we clear? Now what happens in the right side failure? Opposite. Now please understand that muscle abnormalities, they don't have to come from, how should I say it, just simply from working against pressure. It can be an infectious process. Does that make sense? Of course, since microbiology is my passion, I can't not to talk. But for instance, there's an infection called South American trypanosomiasis, also known as Chagas disease. People with chronic Chagas disease, they develop congestive heart failure because one of the sides, ultimately due to the infection, becomes less functional, develops dilated cardiomyopathy, and then you have the problem. So in case of right side failure, you have peripheral congestion or systemic congestion. You have spelling problems today. Peripheral congestion, and that results in a systemic edema, peripheral edema. And like portal hypertension. Etc. Does that make sense? The problem with congestive heart failure, if it is due to the cardiomyopathy, like you cannot do much about it. For instance, if somebody has coronary atherosclerosis, plaques in the coronary arteries, you can do balloon angioplasty, you can put shunts. So there are some not permanent, but interventions. In case of CHF, the ultimate intervention is heart transplant. You can't do much about the muscle. Does that make sense? Questions? You good? Okay.
Wait, can you summarize it again?
About what? Left side or right side?
The
So-
left side, the left side.
So, okay, basic, right?
The left, yeah.
Okay, so let's put it like in a general perspective. If one side fails, blood accumulates in the opposite side. Does that make sense? So if left side fails, which is systemic circuit, does that make sense? Left side fails, not enough blood goes into the systemic circuit, so blood congests, accumulates in the pulmonary circuit. Pulmonary circuit is not built for that amount of blood. It results in pulmonary hypertension and pulmonary edema. When right side fails, okay, when right side fails, which pumps to the lungs, okay, then excessive blood accumulates, gets congested into the systemic circuit, which leads to hypertension in the systemic circuit and peripheral edema. Edema in like legs or arms, Does that make sense?
The thing that causes it to fail is when it
What
swells.
what causes it to fail?
Yeah, you said
The
you
heart?
mentioned the ventricle when it starts to swell and the blood
Well,
can't go through.
There are two options. One of them is overgrowth of cardiac muscle. Does that make sense? When cardiac muscle occupies the space for blood. So it grows inwards, which makes the ventricle smaller. Does that make sense? And another option is when it becomes like ballooning, like inflating. So walls of the ventricle are relatively thin. The volume is much more than normal, dilated cardiomyopathy, and it can't normally pump. Does that make sense? Better sense? Good? Okay. So